we sitting to? All right. Good afternoon, everyone. Welcome to this joint seminar held by the core and the Department of Epidemiology, Biostatistics, and Occupational Health. As part of this series, we're trying to introduce everyone to researchers who've been active in clinical research. And today I'm very pleased to present to you Dr. Brown. Dr. Karen Brown graduated from the University of Toronto in medicine. And in 1990, she was recruited here at the Montreal Children's Hospital, the Department of Pediatric Anesthesia. And she has spent her career over here and also done quite a lot of research simultaneously with her clinical practice. Sleep apnea was at that time, the time that she was hired, an emerging and major indication for tonsillectomy in children. And in collaboration with the MCH Sleep Lab, directed by Dr. Robert Bruyette, Dr. Brown published several papers on perioperative respiratory complications following tonsillectomy. In collaboration with Dr. Emanuela Moss of respiratory medicine, she reported a heightened respiratory opioid sensitivity in children with severe recurrent nocturnal hypoxemia. In 2017, following reports of some important post-tonsillectomy pain, Dr. Brown and colleagues conducted a prospective study asking parents to report their experience at home. And it's the analysis of these data that she's going to be sharing with us today. I think what is interesting is how data collected here at the McGill University Health Center can be used to provide insights. Thank you, Dr. Brown.
Can everybody hear me? How do we know if they hear me online? I see. So Nandini, thank you very much for inviting me to this, to give this talk. So this study was a collaboration between the Department of Anesthesia, the Department of Surgery, and you guys. And so we thought you'd find it interesting, and I have nothing to declare. So Dr. Nandini's objective is to foster collaboration between clinical research and core. I don't think she knows this, but I've been collaborating with the core and its various iterations for quite a long time, because I decided very early in my career that statistics was not my forte. In fact, for many of you, you'd be appalled at how little statistical knowledge I have, but I collaborate with the statisticians. So way back in 2002, when Robert Platt had just arrived from Chapel Hill, we collaborated on a study, and I learned something about Loess plots, which I'd never heard of before. And then we, with Dr. Bruyette, we assessed risk for respiratory complications. And again, the statistical analysis, we acknowledged input from the, I think it was called the outcomes. We just called it statistical analysis, but this was Robert Platt. Again, I learned something about the Akaki information criteria. And then we devised we changed our practice and collaborated with Dr. Jun Zhang, and he accepted authorship. Or no, he for some reason, the statistical consultation was done as a consult at that point, and he felt it didn't warrant authorship. But then we did a follow-up study again in 2006 or 2000. We published it in 2010, and Jun Zhang was a author on this. And then related to the current study, we're using pain scales, and we did a validation of the pain scale and collaborated with Raman up at the core up at the Montreal General. So I've been with you a long time. And this study, which has taken quite a bit of time to get published and which was accepted by the British Journal of Anesthesia, as I said, is a collaboration between clinicians, anesthetists, surgeons, and the core. So my objectives, so I think we have satisfied Nandini's objective, or at least my practice has. My objectives were to discuss with you and show some of the challenges presented by real world data. And this we obtained from parents in the home environment, which is a tricky environment to get data from. And we, in the statistical analysis, we used mice for imputation of missing data, and we fitted trajectories. And I would like to discuss that with you and show you some of our results and how we interpreted the results and linked them to the clinical practice. And another aspect that I'd like to discuss with you is some of the challenges that we had in trying to bring the paper to publication in a clinical journal, because we wanted to publish in a clinical journal because that's the way you influence practice. So just as a background for sleep apnea is a disorder, and characterizing the disorder are two physiologic stimuli. One is recurrent hypoxemia during sleep, and the other is sleep fragmentation. And these two stimuli have been linked to mediators that are linked to cardiovascular disease and the metabolic syndrome and other aspects of the sleep apnea syndrome. But these inflammatory mediators also are linked to pain and pain modulation. And so one of the problems following tonsillectomy for sleep apnea is pain. And many studies have reported pain. So this figure is from an Ottawa study published in the Canadian Journal for postoperative days at home. And on the y-axis is the pain scale, which is a measure of pain severity. And they were testing two different kinds of analgesics. And the horizontal line is the threshold for clinically relevant pain. So you can see that in this population of children following tonsillectomy, that pain, clinically relevant pain, lasts for at least the first week. And that had been published by numerous authors. And so our hypothesis was the severity of sleep apnea linked to the severity of postoperative pain. So our exposure variable was the metric for severity, and the outcome was the pain score as a measure of pain. And the gold standard for the severity of sleep apnea is polysomnography, which simply isn't practical because it's too expensive and it's limited to specialty sleep labs. And so that was not going to be a variable that we could use. But in 2013, Tate, a group from Chicago, Ann Arbor, devised a 5-item questionnaire assessing the severity of the obstructive breathing during sleep. And those are the first 4 items. So the loudness of breathing, the frequency of breathing, whether the child seems to be struggling when they breathe, and if the parents ever notice some apnea during breathing. So those 4 questions link to the physiologic stimulus of chronic intermittent hypoxia, because if you obstruct your airway, you're going to turn blue. And the 5th question dealt with the quality of sleep. So did the children awaken refreshed or not? And so that's our exposure variable. And the outcome variable was the parents' postoperative pain measure. This is a pain scale that was developed in the IWK in Halifax and well validated in children 2 to 12 years of age. So we taught the families how to use the use the scale 15 items to assess if the child's behavior had changed. It's a behavioral pain scale postoperatively. And we asked the parents to fill it out twice daily for 14 postoperative days. Whoops, sorry. And so we made a diary, and that's the diary, and you can see the 15 items and longitudinally across 14 postoperative days, and the parents would fill in yes or no to a behavioral change. And in addition, we asked them to fill out if they gave analgesic medication on that day. So this, in orange, are the questions from reviewers as we presented the paper, submitted the paper. And one of the questions was, I'm no expert in statistics, but I have trouble understanding the power analysis and sample size calculation. This is always the thing, clinical journals, power sample size. And they wanted further clarification of the sample size. So we had done a sample size calculation because when Tate proposed the STBUR score, that 5-item score, he dichotomized it. And so we envisioned having a dichotomized STBUR score for severity of the sleep apnea and pain, yes or no. And that's how we came up with our initial sample size of 128. So then we set out to recruit during 2018. And I know you can't read that, but we approached 563 children and we recruited 319 children. Two of them withdrew. We excluded them if they were operated on for bleeds. So we had 310 patients that filled diaries. And that's the first problem that we had, because we asked the families to mail in the diaries to us. And of course, we had attrition, and only 65 families didn't mail them in at all, were lost to follow-up. But of the ones that did send in the diaries, we had quite a lot of missing data, so that we only had 51%, 124 children with complete diaries for 14 days. Actually, that was for 10 days. And so that was problem number one that we encountered with the data. And this is the box plots for the 14 postoperative days and 28 observations, showing the variance in the pain severity. The pain severity is on the y-axis across time and across the groups. And you can see there's a huge amount of variability. And the red dotted line is the threshold for clinically relevant pain. So we thought that within this spread of data, there was probably a trajectory analysis could be useful, because clearly it seemed to us there was more than one population of children in this pain severity. And so that's when we came to collaborate with the core, because we had clinical expertise in sleep apnea, we had clinical expertise in pain, ambulatory tonsillectomy, and then we encountered this missingness, and how were we going to deal with the missingness? And because we wanted to fit trajectories, and to fit trajectories, we needed a big sample size in order to fit trajectories. And this is the kind of missing data. So in order to mitigate missing data, we had a dedicated cell phone to contact the patients, and the parents through SMS and picture messaging would send us the diaries. So in an effort to try and have as little missing data as possible, but still you can see that there's some days when the families, which is the laser is the, I don't want to do it wrong here. Whoops, oh shoot. Their whole days when they missed because they may have forgotten. And within the 15 items, they only answered some of them. So we had the missing data. And so that was one of the questions from the reviewers. You know, the data was collected in 2018 and the manuscript was submitted in 2025. How come it took so long? And why was there such a long interval? And the reason there was a long interval is it was not an easy problem to sort this missingness in order to do a trajectory analysis. And that's when we learned about Donald Rubin, whom I'm sure you know about Rubin's typology for missing data. So he classifies missing at random and missing not at random, because most of the statistical analysis assume data missing at random. And because we knew that it was burdensome for the families to be filling out the questionnaire for 14 consecutive days, we said that if their pain scores were 0 for 2 consecutive days, they could drop out. So that data is not missing at random. And we spent an enormous amount of time initially with Dr. Correa up at McGill and with Russ Steele, sorting out what to do with how to manage the missing at random data and the missing not at random data. And initially, we were trying Bayesian imputation. Menglin Peng had was finishing her PhD up at McGill, and she was interested in Bayesian imputation. So that's how she became involved in the study. So we worked on that for a year to try and sort out what to do. And we decided, because the parents who stopped because the pain, they were having 0 scores and not giving pain medication, that we would add zeros from the data that was missing back until the first entry to deal with the missing at random. And for everything else, initially we tried Bayesian imputation and we couldn't make it work. And then we had collaborated with Roman for the validation study, and he was aware of the missing data and thought it would be interesting to try mice. And so we collaborated with Roman for the rest of the study to impute with mice. And I know you know all about mice, but I learned about mice. And that's how we imputed the rest of the total scores, not the individual items, but the total scores. So for me as a clinician, this is a tapestry from the 1300s, which shows Alexander the Great heading into the east, into the great darkness. And for me, as a clinician, imputation was a bit like heading into the unknown and the darkness, because many clinicians feel that imputation is just making up data. And so I knew if we were going to be publishing in a clinical journal, we would have to convince clinicians that the imputation was valid. So for our mice model, we used 7 variables, some binary and some continuous. We used gender, the day of discharge from hospital, their age, weight, the STBUR score, the PPPM scores, and we had a second reference pain scale. And we used a combination. Of course, I'm using the royal we because Roman is the one who spearheaded this analysis. We used both linear regression or predictive mean matching and logistic regression in the mice framework. 50 iterations, and all the data converged. And we felt that the adding zeros was a data-informed strategy, which minimized bias. And so that this was a reasonable. And then we did some sensitivity analysis of the imputation. So this shows, again, on the x-axis, the longitudinally across the 10 postoperative days, and the pain scale on the y-axis. And you can see the blue is the actual data, so that's complete data. And the red is the imputed data. And initially they're bang on. And towards the end of the study, they started to deviate a bit, but we thought it was plausible imputation for the initial 10 postoperative days, 20 time points. So we between 14 days in the first column and the 10 postoperative days, by reducing the analysis to 10 postoperative days, we had 51% complete data and 49% with missing data, and some of it was missing at the start, and some of it was missing in gaps. some of the analgesic cessation is the ones who stopped because they weren't having pain anymore. And then we had attrition. So that was how the that was how we managed the missing data. And said, so some of the reviewers said the methodology for modeling and managing missing data and imputation seems quite sophisticated and logical. There was quite a bit of statistical maneuvering and actually asked how many data points were missing. So there were potentially 4,900 PPPM scores, and 19% of subjects had at least one missing score, but only 17% of the total were missing. So it's not that bad. Anyway. So in addition, some of the families had partial scores. You know, they didn't fill out all of the 15 items, so we called those partial scores, and most of them were missing one or two items. So we figured that the imputed score should lie somewhere between what the parents recorded as the score and the maximum possible if the missing score had been assigned 1. And so we looked at the discrepancy, and we found that the difference between the imputed and the partial scores was about 0.7. So, which is pretty close. So we thought those two sensitivity analysis suggested that we had plausible estimates for the imputation. Oh, shoot. I hit the wrong button. So because we now decided that we were going to do a trajectory analysis, the sample size calculation that we had initially thought of as a dichotomized study was not really valid. And trying to figure out a trajectory or a sample size for a trajectory analysis is tricky, and there's not a lot of data on that. So as a general rule, 50 to 100 subjects per group, Raman felt was a reasonable allocation for trajectory analysis. And we had 245 subjects. So in parallel with the imputation, we also were playing with the complete data to look at the to fit trajectories. And initially we started with the complete data set of 87 for 14 days, and then we were playing with the down to 10 days, but we used the criteria for choosing the optimal model was based on the Bayesian information criterion, and we wanted the lowest Bayesian BIC possible, and the assignment of the linear polynomial or quadratic equations. Initially, we started with 5 trajectories, and you can see there's a lot of overlap, and some of the groups were very small. So we used proc-traj at the SAS to do the trajectories, and so then we decreased to 4 models, and again you can see 2 of them are still overlapping quite a bit. And as the selection criteria were the BIC and the highest entropy and a minimum trajectory group of 5% of the sample and model stability. So the last thing that we did in choosing the trajectory was to take proc-traj and in the complete data set, assign the trajectories versus the trajectory assigned in the data set of 245. And there was a big shift so that the size was too small. And so for that reason, we decided on a 3 trajectory model. And so the 3 trajectories, they separated very nicely. And we decided that was the model we would go with. And the confidence intervals on the trajectories were pretty tight. And so then when we submitted the paper, the clinical reviewers, of course, said there's too much space in the manuscript for the trajectories and the modelization, and they wanted less, but the statistical reviewer wanted more. So that's one of the problems. And the problem with the clinical papers is that you're limited by words. So we dealt with this by using appendices and supplementary material, but that's of the problem. So the statistical reviewer wanted a statistical analysis of the quadratic equations defining the trajectories. And so we discovered Don Rubin again had Rubin's rules, where you could use the quadratic equations to come up with a statistical analysis and variance on the trajectories. And this Raman did. And so to show that there was statistical difference in the trajectories. And then we did a sensitivity analysis where we superimposed the trajectories from the complete data set of 245 compared to the imputed data set of 245 and the complete data set of 124, and they map very closely. And on the y-axis, we linked the pain severity to the World Health Organization echelon, so between mild, moderate, and severe pain. And they separated it out very nicely. And the other thing is that it became obvious at the first data point, post-op day 1, which trajectory class the group belonged to, which is clinically important. But come to that. So then that statistical reviewer wanted to know how the trajectories could inform clinical management. So on the statistical significance, that's the data from Rubin's rules on the quadratic equations, but then we linked it to the time points and the days postoperatively. So for trajectory 1 and 2, which were the lower pain, the highest score was on post-op day 1. But for trajectory 3, which was the most severe group, the pain scores escalated and they peaked on post-op day 3. And not only that, it showed that the duration of pain, it didn't, in trajectory 3, it didn't resolve until post-op day 9. So it's a lot of, in that trajectory 3 group, which is a severe pain group, it lasts a long time, the pain. And we combined this. In clinical journals, you're limited in how many figures you can use. So we combined the table and the figure as a single figure. It didn't count as an extra one. So this is the demographic data, and I know you can't possibly read it, but it showed that there were differences across the trajectories, such that in trajectory 3, the severe group, the children were younger. And in the trajectory 3 group, they had higher STBUR scores. And the other outcome variable that we measured was whether or not the patients returned to hospital, because they would return to hospital for pain. And there was a higher rate of revisits and also of readmission in the high pain group, which is what you would expect. So then we wanted to evaluate it in this group-based trajectory analysis, who were the children in each of the groups. And we looked at various predictors, 2 models, trajectory 2 versus trajectory 3, and trajectory 1 versus trajectory 3. And for both groups, the STBUR score was predictive of the trajectory group. And in addition, in the mild versus severe group, there was an interaction term between age. And in terms of revisits to hospital, we did linear regression for this, logistic regression for this. And the trajectory group was the only predictor of return to hospital for pain. So that one of the questions from the reviewers was, it's been 7 years since you started. What if practice has changed? And practice has changed because the surgeons are now using a different surgical procedure that is less painful. But it doesn't change the fact that the study showed that the severity of sleep apnea was linked to the severity of pain. And so that is still valid, that the even if the practice has changed a bit, we showed that there's an association between the severity of sleep apnea and the severity of pain. So to conclude, we showed that there were three distinct trajectories describing the pain severity, the pain evolution, and the pain resolution, that it was predicted on post-op day 1, that trajectory 2 and trajectory 3 had higher rates of visits for pain, and that a higher preoperative STBUR predicted more pain. And then we had the interaction term. So the other problem that we had clinically is that nobody knew what the best analgesic cocktail, oral analgesic cocktail at home was. There was very little data. Most studies have only looked at the first day or 2 after tonsillectomy. Very few have looked at oral medications. And so we had this data from the parents about when they gave medication. And when we looked at the 124 children with complete pain scores, here the trajectory, the blue is the mildest pain, and the darker one is the severe pain. You can see that the gray line, which is the severe pain, took more medications. There were 3 medications: acetaminophen, ibuprofen, and morphine, that are used to control pain post-tonsillectomy, and that the more severe group took more analgesic. So then we were interested in looking at comparing combinations, because we don't know what's the best combination. And because the parents had done the study, had recorded pain scores morning and night, that's ANOVA, that's repeated measures. And they told us if they gave medication or not. So we looked at analgesic A and the pain scores on the morning and the afternoon, and versus analgesic B on the pain. And we looked at it with what did we use here? I think it was logistic regression. Anyway, we looked at, there were 2,300 observations looking at different combinations, acetaminophen alone versus nothing, comparing acetaminophen plus ibuprofen alone, to see if we could get any idea of what was useful and what wasn't useful for data, which we currently didn't have. So for all of the analgesics, acetaminophen, ibuprofen, and morphine, giving something versus nothing was better. Giving something was better than giving nothing. But we actually didn't show, comparing acetaminophen plus ibuprofen versus either alone, didn't show any statistical difference. Adding morphine was more effective than the acetaminophen ibuprofen alone. So that was that. And then when we looked at it across trajectories, now, but here the numbers are getting low because the total number of observations that in patients that received morphine was lower. So the numbers are getting lower, but the adding morphine for trajectory 1 and trajectory 2 to the acetaminophen ibuprofen combination further decreased the pain scores, but not in trajectory 3. And one of the issues with morphine is the dose. So as it turned out, the dose of morphine prescribed to the trajectory 3 group was less. 37% of them were prescribed a very small oral morphine dose. So it may be that the dose was the issue. So in terms of the objective of that we had hoped to show and to see if we did it or not, in terms of the challenges of real world data, we tried using a dedicated cell phone and SMS messaging to families every 3 days postoperatively, and I think that helped to decrease missingness, but it didn't completely. We still had missingness. We had missing, there were patients that withdrew, there were gaps and attrition. But we believe the parents' report. One of the reviewers commented that we should have had a pharmacy check to see if the patients had actually given, but we believe the parents' pain scores, and we believe the parents when they wrote that they gave the drug or didn't give the drug. Another major criticism was a lack of standardization in the analgesic management of patients. But the problem was in 2018, there was no consensus amongst the surgeons. All the surgeons had been in practice for decades. They felt strongly that their cocktail was the best cocktail, and there was no willingness to have a standardized analgesic or anesthetic management for children. So this is just the practice that we were in. And we added zeros to the clinically informed missing data and used mice for the missing at random data, and evaluated the performance of mice with convergence and with sensitivity analysis. Whoops. And for fitting the trajectories, we used time points as continuous variables. So it didn't matter if the families recorded the morning and afternoon pain scales at the same clock time, because we treated the time points as continuous variables. And we defined 4 selection criteria for the model selection of the trajectories, and did perform sensitivity analysis to select the 3 trajectory model. And then with the 3 trajectory model, we used Rubin's rules to show the statistical significance in the trajectories. And we showed a sensitivity analysis between the complete and the simulated data set for the trajectory groups. And yes, it's true that the study design was not standardized, but we used generalized linear mixed models to analyze the data. And we, as I said, one of the outcomes was the surgical outcome, because we wanted to comment on whether the data was generalizable to the practice of tonsillectomy in children, and our surgical outcomes and revisits were agreed well with the published literature. And we interpreted the data for a clinical message. And I think that's all I have to say.
Any questions from the audience at EBOH? Okay. Okay, all right. So
thank you for the presentation. I have a question about the imputation process with the mice data. As I know, for the imputation, we always have for example, a matrix of data, and we have some missingness. We use the data that we already have for humans, and we do, for example, mean imputation with based on the data that we have. You said we used mice to complete to impute the missing data. Is it you have a different, you have a set of mice, you did all the 14-day postoperative data in a for example timesheet or something? Then I don't know how you combine the mice data with the human data. How?
I told you that you would be shocked at how little statistics I know. I don't know if I can answer that question. And Raman is not here.
Okay.
So I don't know if I can answer that question. But the mice, that's what we used for the mice model. And I don't know if I can answer that question.
So you trained the model on the mice data, then you use that model to predict the missing data on the human subjects, I guess.
I have a feeling that your perception is coming from data science. You're thinking of a prediction a model development type vocabulary is what I'm hearing from you, a training set and a validation set. So that is not how this works. So this is mice multiple imputation is a common methodology used in statistics when you have missing data. And it depends, of course, what is missing. Let's say here that outcome was missing. The outcome is
Score, the pain
score.
score.
The pain score is missing. The pain score is a random variable in this trajectory model. It follows a certain probability distribution. And that probability distribution is, yes, it's, fit with the best, available information from those who have been observed. But then it is that distribution is used to impute or guess what are the values of those people who were not, for those who are missing pain scores. And, and that's a sort of very gross description of what is happening, but there's no training and validation set. You're trying to fill in the blanks, basically. That is what is happening. Right. I wouldn't call it training. There's some criterion, like let's say try to find the maximize the likelihood or something like that. And there are over several iterations that criterion is satisfied, and it's at that point that you have stable estimates.
That sounds like what we did.
There are some questions coming up now here.
The first question is a simple one. How were the variables chosen for the mice model?
Well, we wanted variables that would reflect the characteristics of the children. So, I mean, gender and age and weight and the STBUR score and were obvious ones. The pain score and the reference pain scale were additional ones. And then the day of discharge, so tonsillectomy is the children are either discharged on the day of surgery or the following day if they are a higher risk group. If they're less than 3 years of age, then they're kept in hospital. So we thought that that was a patient variable. And when we added it to the mice model, it seemed to be better. So that we chose them because we thought they reflected the patient characteristics.
The next question is, if you choose not to publish in a clinical journal, would it be easier to publish this article in a statistical journal, or what are the different challenges?
Well, we discussed that, and Roman thought that this was not sufficiently novel to justify publishing in a statistical journal because the mice is a well accepted statistical analysis. So we discussed it, but we didn't think it was sufficiently novel to warrant publishing in a statistical journal.
Was there any conditioning on removal of adenoids with tonsils?
No.
Simple answer.
The adenoidectomy compared to tonsillectomy is not particularly painful. The problem with tonsillectomy is they remove the capsule of the tonsil, separating it from the underlying muscle, and that's what's painful. Adenoidectomy, surprisingly, is not particularly painful.
This person says, perhaps I missed it. How did you define day of discharge as a binary variable in your mice model?
So day of discharge was binary because it was either discharge on the surgical day or not. So most were discharged the following day. Some stayed a little bit longer, but we dichotomized it as day of surgery or not for that variable.
You mean that variable recorded whether a subject was discharged on the day of surgery?
Yes.
Yes or no?
Yes.
I actually want to just go over a little bit the trajectories. For one, yes, the three trajectories that you have. You started this whole analysis wanting to you know identify, I guess, clusters of children, because your very first box plot presentation showed that there's some kind of gradation, but you hypothesize that there's different children have different trajectories over time. And so how did you interpret these three trajectories? What do these three trajectories mean?
Well, we on the y-axis, which is the pain scale, pain severity, according to the WHO criteria, is mild, moderate, or severe. So we took those categories and linked them to the PPPM score. And as it turned out, the trajectories happened to fall into the mild, moderate, or severe categories. And from the initial work with the PPPM, a PPPM of 6, a pain score of 6 is clinically relevant pain. So that trajectory 1, which is the bottom one, it's below 6 for the entire postoperative period. So that group, which is I think 100 and some odd children, the vast majority of them had no pain, but clearly a group, the trajectory 3 group, had severe pain that escalated. So the maximum pain was at post-op day 3 to 5, and pain lasted into the second postoperative week. And so then we wanted to know who those children were, and they were the ones with the higher STBUR scores, so the higher severity of sleep disorder breathing, and they were younger.
So there was those children with a greater risk of sleep apnea were the ones indeed who had a more severe pain.
That's what we showed.
Okay. And
which is new,
okay.
which is a novel finding.
Okay.
And it links in the sense that chronic intermittent hypoxia and sleep fragmentation are linked to the inflammatory mediators, which may modulate pain. That is how we interpret it.
And is the STBUR score something that's available at the time of surgery or prior to?
So the STBUR score it's a simple little score. It's 5 items, but it's proven very useful. It predicts the children who will have postoperative respiratory complications. It predicts the children who are more sensitive to opioids. One of the problems of severe sleep apnea is that they may be more sensitive to opioids. So Tate showed that there were more opioid-related respiratory events. It's been endorsed by the association, the ambulatory SAMBA, Society of Ambulatory Anesthesia, and they recommend it for evaluation of children.
I still don't understand. Come on.
Is someone? Eh? Oh. And did they say something? Did they want to say something? Oh, I see. And we implemented it in 2015 in our pre-op clinic, and we routinely, for all children going through the pre-op clinic, we administer this STBUR.
Okay. So, how has this study changed practice at your location?
Well, we're just getting it published.
Okay.
So how has it changed? The surgeons have changed their surgery. So instead of doing a total tonsillectomy where they remove the capsule, which is so painful, they are doing a partial tonsillectomy where they incise the capsule, remove the tonsillar tissue, and that's much less painful. And they're doing a study to see if how that affects pain.
Oh, all right. And are they bringing in that change primarily for the children with the highest STBUR scores?
No, they've not dichotomized that.
All right.
But that's the thing.
Yeah.
I hope they're tracking that.
Okay. And my last question. Okay. Is you explained a little bit, but I lost that detail. How you selected 3 rather than 4 trajectories? Could you just go over that again, please?
let me see, where was that? So we chose 3 because in looking at when we were dealing with the 4 trajectory model with the imputed data set, one of the things we noticed is that the bottom 2 tend to overlap a bit. They're all pretty close. The 2 of them are pretty close to 6. So that was one thing. But when we compared the allocation here between the trajectory determined from the simulated data set of 245 versus if we took the complete data set and ran proc-traj on the complete data set and looked at how the group allocation was, you can see that in the I wish I knew how to use the point. Maybe this is the point. Oh, there we go. In trajectory 1, in the complete data set, there are only 3. It's too small because one of their criteria was that we had to be at least 5% of the sample as a selection criteria for the trajectories. So based on that, we moved to the 3 trajectory model.
Sorry again. Yeah. So, what is the stable showing us on along the rows and the columns?
So these are the trajectories determined from the complete data set of 122, and these are the trajectory assignments for the simulated data set of 245, and the group membership for the 245 group is acceptable, but the group membership for the complete data set, it's too small for trajectory 1. So 4 trajectories we thought that was not, and so we went to 3.
Interestingly, your simulated or your imputed data allowed you to split trajectories. The imputed data seems to have 4 trajectories. Am I right?
Yes, 1, 2, 3, 4.
Okay.
Yes.
Okay, but when you sort of compare that to the observed data, you reduce that to 3.
Well,
No.
when we ran proc-traj on the observed data of 122 patients, the group assignment was too small because there's only 3 in the trajectory 1, and that was one of the criteria for selecting the model. So therefore, we went to a 3 trajectory model. That was one of the sensitivity analysis that we ran.
Thank you. Yes. Yeah, please.
There's a question at McGill. Go ahead.
Trajectory modeling is relatively new to myself. What is it's my understanding that there is or not propensity, but there is the potential for there to be spurious trajectories produced with it. Can I ask how those are, how it's determined whether a trajectory that is produced from this model is spurious or otherwise?
I cannot answer that question. I don't know.
I think Dr. Brown already I did allude to the answer to that. So at proc-traj, it can be run it's rather like a cluster analysis. So instead of an analysis where you're trying to divide a sample into multiple clusters where the data has been gathered in a cross-sectional manner, here you've got longitudinal data that we're trying to divide into clusters. And based on the criteria that they were using, my understanding is, and it does seem to make sense, that you don't want some of those clusters to be very small because that would suggest that they're spurious. And one of the trajectories that was identified by the program had only 3 observations in it. So they decided that was not a trajectory by itself? And did you collapse? But I suppose you just went from a 4 trajectory model to a 3 trajectory model. So those 3 observations would have gotten redistributed amongst the other 3.
Yes.
Okay.
Exactly. And then when we looked at the when we superimposed the simulated trajectories versus the complete data set, they map very well. And we figured out the number in each group, and I don't have it off the top of my head, but it's in the paper. So that's what we did. But the problem with the complete data set is it's only 124. So it's not really enough to do a trajectory analysis. That's why we needed the imputed data set of 245 in order to have at least 50 patients per trajectory.
Any more questions? Well, Dr. Brown has mentioned Raman and the Biostatistics Consulting Unit. If you have any questions regarding the unit, please don't hesitate to visit the website. This is one of the subsections on our Research Institute website, the Biostatistics Consulting Unit, or BCU. And please don't hesitate to reach out to them for any questions and guidance in your challenges. Dr. Brown, thank you so much for coming.
Thank you.
And it's been a wonderful talk.
It's been a wonderful collaboration with your department in all its various iterations.
Thank you.